by the end of this presentation, you should be able to discuss normal 12 lead ECG, read normal ECG and cardiac monitor tracing, diagnose major abnormalities of rhythm, rate, and ischemic heart disease. This is the key which you can call this key as Saqib's 14 points for reading ECG. These are the 14 points. By applying these 14 points, you can read ECG in about 2 minutes, and you can pick the major changes in the ECG. ECG is very important for all the anesthetists, rather for all the doctors. But for anesthetist, it is very important because during anesthesia, you continuously monitor the ECG tracing, and for any intervention, you need continuous ECG monitoring. This is basic monitoring for anesthesia delivery. And secondly, when you are doing pre-anesthesia assessment, ECG is important. Below 40 years, if there are symptoms of cardiovascular disease, you can order ECG. But after 40 years, it is essential to do ECG and for to pick any abnormality in the cardiac system, cardiovascular system. And these are the points which we will discuss in the following slides. The reverse of this page is this, and I shared these pages in the group, WhatsApp group, and you must have read. And I also shared the literature for reading ECG, and I think you people must have read something about ECG, and this will inshallah benefit you in this presentation for learning something from this presentation. Electrocardiogram is the recording of the electrical activity of the myocardium. It is not the single cell which is showing its current in the ECG. It's a combined effect of the atria and then the ventricles. And the pulse starts from sinoatrial node, this sinoatrial node, and then it spreads into the both the atria, and depolarizes the atria, and you can see there's the Batchman's bundle and the other uh, conductive tissues, and then it comes to the AV node, and then goes to the bundle of His, and then right bundle branch and left bundle branch, Purkinje fibers, and then depolarizes the myocardium. One thing you should remember, that depolarization means excitation. Depolarization means contraction of the myocardium, excitation. And repolarization means the resting phase, relaxation. And depolarization means systole. Repolarization means diastole, that their heart will relax. So if you see on the for the tracing, ECG tracing, it will be like this. First of all is the ECG is all about this QRST complex. This is all about QRST complex. If you concentrate on QRST complex, whenever you start seeing ECG, start from P wave and look for the following QRS complex, and after the QRS complex, look for the T wave. So this will be you when you at the ECG, you will start by looking at P wave, QRS complex, and T wave. It's all about ECG. So when you recognize the normal ECG, then you will be uh, able to pick up the abnormalities. If you see in this ECG, in this slide, you see this is the P wave, this is the PQ segment and a PR segment, QRS complex. This is the J point. And mind you, this is the isoelectric line. This isoelectric line, any deflection upwards will be positive deflection or upward deflection. And any downward deflection will be negative deflection or downward deflection or depression. Any elevation above this isoelectric line will be elevation. So this is the J point, and this is the ST segment, the T wave, the ST interval, and here is this is QT interval. This is QT interval, and from this P to the start of the Q wave is the PR interval. Traditionally, it is called it. Actually, it is PQ interval, but we call it PR. Sometimes it Q wave is not always present, so we call it PR interval. And you can see that these are the large box. This is we call a large box. And within these large box are the five small box, upward and downwards, five and one. This one box, five small boxes length, five small boxes height, and the the speed of the paper is 25 millimeter per second. This means that five large boxes will pass from this the writing pin at the speed of 25 millimeter per second. In 1 second, five large boxes will pass. So in uh, in 5 seconds, if one trace comes, in five large boxes, one trace comes, the rate will be 60 beats per minute. That we will discuss in the this rate calculation. And here you can see that the calculation of the time, one small box is equal to 0.04 second or 40 millisecond, and one large box, this large box is equal to zero point 0.2 second or 200 millisecond. So any of the wave, when you measure the length of the wave, you will calculate it or describe it in the terms of the boxes or the time. If I say that this P wave is two small boxes wide, so this is the 0.08 seconds wide or 80 milliseconds wide, or you can say two small boxes wide. And the PR interval, you can say that it is four small boxes wide. So and the height of the wave, it is described in the millimeters, that it is 5 millimeters high, 10 millimeters high, or it is a five small boxes high, or uh, seven small boxes high. So in this way, you can describe the height and the width of the waves and the segments. The interval always includes a wave. PR interval includes the P wave. The ST interval includes the T wave. The TP interval includes the U wave. The RR interval includes many waves. So any interval, and the segment does not include any wave. This is ST segment. This is PQ segment, and like this. So from this, and we will refer to this slide again and again, just for the normal ECG. So this is the 12 lead ECG, and in this ECG you can see uh, three bipolar leads, one, two, three, and three unipolar leads, AVR, AVL, AVF, and six chest leads. We apply four limb electrodes and six chest electrodes, and the ECG machine gives us 12 leads, 12 leads ECG. AVR stands for augmented voltage right arm, AVL augmented voltage left arm, AVF augmented voltage foot. It is applied to the left foot. So the rule is that when the current is flowing towards the positive of a lead, the positive deflection will come in on the in the ECG tracing. And when it is flowing, current is flowing away from the positive pole of the lead, the deflection will be downwards. And in lead one, the positive pole is on the left shoulder, and the negative pole is on the right shoulder. So when the current is flowing towards uh, uh, the positive pole of lead one, the deflection will be positive in the tracing. So we come to the first point of Saqib's 14 points for reading ECG. The first point is the AVR. First point is AVR. So first, in the operation theater, you are looking at this tracing on the cardiac monitor, and in this you will not be able to see some things, some of the abnormalities. But usually you focus on the lead 2 or CS5. CS5 you can make by applying the this left arm lead in the fifth intercostal space in the anterior axillary line. When you will apply electrodes like this, this will become CS5, and this will give you a V5 chest lead. And this usually we use lead 2 because this lead is called rhythm lead, that we will again discuss in the later slides. These are the slides which these are the electrodes which we apply to the right arm, left leg, and the right leg. And the mnemonic for to remember is read your green book. Read, uh, hand on the right shoulder, your on the left shoulder, green on the left leg, and a book on the right leg. Read your green book. And these are the chest leads. The V1 is applied to the left of the sternum in the fourth intercostal space. V2 is in front of the V1, and V4 is between V3 and V5, and V5 is in the fifth intercostal space and at the anterior axillary line, and V4 is in the mid clavicular line, and V6 is in the mid axillary line in the fifth intercostal space. And just as a mention that the R wave takes takes off from V1 to V6. That means that the R wave will be very small in V1 in normal ECG, and it will increase in the amplitude from V1 to V6 normally, in the normal ECG. This is the 12 lead ECG. We already discussed that we have these three unipolar leads, three bipolar leads, and three unipolar leads, and these six chest leads. And this is the lead 2, and this is called the rhythm lead. And that's why we always order long lead 2. Long lead 2 is always included in the good ECG. So first point in the 14 points is the AVR. AVR, first of all, you will, when you see a 12 lead ECG, you will look at the AVR. AVR should be negative. All the these waves P, Q, R, S should be negative in the AVR. So whenever you receive the this tracing, 12 lead tracing, first look at the AVR. It should be negative. If it is positive, there are two possibilities. One is that one is that this patient is the leads are reversed. Leads are not correctly placed. The second is that the patient is dextrocardiac. The patient's heart is on the other side, or patient is having situs inversus. So when you will listen to the chest, the heart will be on the other side. So first, your point will be AVR. You will look on the AVR. It should be negative. Second thing, whenever you will be learning ECG, people will be teaching you with the rate, but we will see the rhythm first. Why rhythm first? Because for the rate calculation, we need to know that patient is having a regular rhythm or irregular rhythm. For rhythm, you will see lead 2, long lead 2, and for the rhythm, you will see the R to R distance. R to R distance. In all the leads, R to R distance should be equal. The second thing you will look is that you will look at the P wave. Every QRS complex should be preceded by a P wave, and every P wave should be followed by QRS complex. And the arrhythmia will be of two types. One is the pattern, irregular or irregular, and other will be the rate arrhythmia. Patient may be having tachyarrhythmia or bradyarrhythmia, and in the irregularity, patient may be having regularly irregular rhythm or irregularly irregular rhythm. And this you can find from by seeing at the long lead 2, and by looking at the P waves and the QR's complexes. And another thing to mention over here is that whenever the rhythm is in the supraventricular part, that means above the bundle of His, or above the AV node, or in the AV node, the QRS complex will be short. It will be narrow. But whenever the rhythm will be ventricular, the QRS complexes will be wide. So this thing will be repeatedly mentioned, that if complex is narrow, the rhythm is supraventricular. This means that it is coming from the sinus or some ectopic focus in the atria, or coming from the junction. So this the first thing is that you want to see the regularity of the rhythm. You will see long lead 2. The RR distances should be equal. Now you look at on these uh, traces. This is the sinus rhythm, normal sinus rhythm, P wave, P wave QRS complex. They will be similar. In a lead to, all the complexes will be similar. All the P waves will be of same type. They will be of same. And another thing to mention is over here is that which you should remember, that this T wave will be of bigger size than the P wave. Is slightly healthy, because when there will be AV dissociation, you will be seeing the P waves and T waves, and you will you will have to distinguish between the P's and the T's. P will be healthier than the T will be healthier than the P wave. So this you should just remember further for the future reference. And now look on at this tracing, that the RR distances are different, and the P waves, there is no pattern of P wave, different P waves. So this is irregular rhythm, this is regular rhythm. This is irregular rhythm, this is normal sinus rhythm. This is normal sinus rhythm. And whenever you see irregular rhythm, the first diagnosis that should come to your mind should be atrial fibrillation. Whenever you see irregular rhythm, first diagnosis should come to your mind should be atrial fibrillation. Is irregular rhythm, no similar P waves, atrial fibrillation, atrial fibrillation, irregular rhythm. So the second point is rhythm. You found that rhythm is irregular, and sometimes there is sinus arrhythmia like this. This is sinus arrhythmia. You will see the P wave from before each QRS complex. P waves will be similar, but because of the variation with the respiration, the sinus rhythm, sinus arrhythmia may occur. And the this about the rate arrhythmia, tachycardia. Normal heart rate is between 60 to 90 beats per minute. The mild tachycardia is 90 to 120 beats per minute. Moderate tachycardia is 120 to 150. Severe tachycardia is 150 to 250 beats per minute. Flutter is 250 to 350. And fibrillation is more than 350 beats per minute. And here, whenever you see narrow complexes, the the rhythm is supraventricular. The narrow complexes, supraventricular tachycardia. You may see P wave, you may not see P wave. As the rate will increase, the P wave will merge into the QRS complex or into the T wave. It will disappear. So for diagnosis, if you see the T wave, you can say it's sinus tachycardia. If you don't see the T wave, you can say it is SVT. This you cannot see P wave, but the complexes are narrow. This is SVT, and rate is about 300, 150, more than 150, about 160. Rate is about 160 beats per minute. And now you can clearly see that the QRS complexes are very wide, and they are not being preceded by the regular P waves, and the complexes are very wide, and this is the rhythm is ventricular. Whenever you see these wide covered complexes, rhythm is ventricular. When you see narrow complexes, rhythm is supraventricular. So this is ventricular tachycardia. Treatment is, what is the treatment, dear friends? Treatment is, if it is pulseless VT, shock, and if it is pulse is there, then you can do pharmacotherapy. So this is the comparison. You can clearly see that in SVT, the complexes are narrow, the P wave is absent. In the VT, the complexes are wide, the height is very, and the complexes are bizarre, and this is VT. This is another slide for of what is diagnosis? Yes, VT. This is VT. What is the diagnosis? What is the rhythm? Exactly. This is ventricular fibrillation. This is ventricular. No particular pattern of the waves. Irregular, irregular pattern, irregular pattern. You see, irregular, bizarre, no pattern you can delineate, delineate in this ECG. This is ventricular fibrillation. Treatment is CPR, CPR and shock and injection adrenaline pattern. Irregular, bizarre. Oh, yes, yes. What is the diagnosis? Yes, torsades, deep pointies, dancing waves, with irregular peaks, dancing torsades point. This can lead to ventricular fibrillation and cardiac arrest. This is same. Whenever you see like this dancing waves, up and down, peaks, torsade, torsade deep pointies, torsade deep pointies. Read friends, what is the diagnosis? What? Fibrillation? No. This is asystole. This is asystole. Now, another rhythm which you will see is the junctional rhythm, and junctional rate is usually 50 to 60 beats per minute, and the P wave may be absent or it will be inverted. Whenever you see absent P wave and narrow complexes and bradycardia, you will say junctional rhythm. And if you see absent P waves but narrow complexes and rate is not very high, this is accelerated junctional rhythm. Okay, so this is a normal junctional rhythm. P wave is inverted and QRS complex is narrow. Okay, one slide. So friends, what is the diagnosis? What is the diagnosis? Yes, this is pacemaker, paced heart, which is I told you, whenever you see wide QRS complexes, this is ventricular rhythm. So the pacer is ventricular. So ventricular pacer, ventricular pace. So the third point, our third point is this. Third point is rate, and in the rate you calculate R to R large boxes, and you uh, divide 300 by the large boxes between two R waves, and R you calculate 1500 and you divide by R to R small boxes, and in the irregular rhythm you count R's in 6 seconds are 30 large boxes, and you multiply by 10, and this will give you the rate. These readings, you should remember these readings. When this R will be here, rate will be 300. When it will be here, it will be 150. When it is here, it will be 100. When it is here, 75, 60, 50, 40, 30. Within seconds, you can determine the rate of the heart by just seeing the R. When R is here, 300, 150, 100, 75, 60, 50, 30, 40, 30. A quick way of calculating the rate. So this is how, friends, can you calculate the rate? 300, 150, 100, 75, 60, 50. Heart rate is 50, and rhythm is sinus. Very good. Sinus rhythm. It is sinus rhythm because we can see P wave, and each P wave is followed by QRS complex, and all the complexes are similar. Okay. And in this, you can see sinus pauses. It is sinus rhythm with sinus pauses. This may be because of sick sinus syndrome. Our next point is the axis, and axis is the vector of the heart, the direction in which the current is flowing. Usually, the current flows from the right side and towards the left side, and this is the normal axis. Normal axis is lies between minus 30 to plus 90 degrees, like this. And how we see the axis in the leads, the when this is the positive end of the lead one, so when it is flowing toward left side, it will give positive deflection in the lead one. And here is the AVF, 2 3 AVF. All these three leads are here, and when it is flowing towards downwards and leftwards, it will give positive deflection in the AVF. This is normal axis. And by the thumb rule, you will raise the right thumb and the left thumb according to the R wave in the lead 1 and AVF. Both thumbs up, normal axis. And when the reaches thumb, the in thumb is downwards in the right and upward in the AVF, they reach each other. Right axis, right reaches its destination. You walk on the right path and you reach your goal. And this right reaches right axis deviation. It comes over here, right axis deviation. And when the in lead one thumb is up, R is upwards, thumb is up, and in lead AVF thumb is down, they're leaving each other. Left leaves and goes away from its destination. Left leaves. Oh, so left axis deviation. They are leaving each other. Left leaves, left axis deviation. And when both leave, extreme axis deviation. Some say that extreme right axis deviation. You may say uh, to avoid the controversy, there is extreme left axis or extreme right axis. You can say extreme axis deviation. Both 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 the thumbs downwards. So lead one and lead AVF, both R's are downwards. So in seconds you find out the axis. Just keep your thumbs in the form in the direction of the R wave and lead one and AVF, and you will say. Both thumbs up, normal axis. Uh, right reaches, right axis deviation. Left leaves, left axis deviation. Both leave, extreme axis deviation. Okay, this is the normal axis minus 30 to 90. Lead 1 positive, lead AVF positive. Left axis deviation, left leaves, right positive, AVF negative because it is going away from AVF. Right axis deviation, right reaches 1 negative, AVF positive, and both negative, extreme axis deviation. So you can see normal axis. You can see left leaves, right reaches, right axis deviation, left leaves, left axis deviation, and extreme axis deviation, both leave. This is the same thing. Axis, what is the axis, friends, in this ECG? One thumb up, AVF down, left leaves, left axis deviation. 1 second, 1 second diagnosis. Okay, next point is our P wave. P wave is formed by the right and left atria, and this is the normal P wave. And P wave is formed by the this depolarization of the atria, and this is high, a tall P wave. Normally, you should remember that this P wave, PR segment, and QRS complex, all these are 2.5 small boxes. 2.5 small boxes, normal, upper limit. Lower limit, maybe two boxes are like that. But the P wave will be in the height. P wave will be two boxes, 2.5 boxes wide, 2.5 boxes height. So if it is more than two and a half boxes wide and 2.5 boxes height more than this will be tall P wave, and we see this P wave in the lead 2 and V1, lead 2 and V1. In lead 2, when you see it a peak P wave, this is because of P pulmonale, and this is because of right atrial hypertrophy, and this occurs in COPD, ILD, interstitial lung disease, and pulmonary hypertension states. Then is the bifid P wave. This is M-shaped. This is P mitral. This occurs in left atrial hypertrophy. This may be in mitral valve disease or in left ventricular failure or like that in those conditions. This is P mitral. And in V1, you also see the P wave. The first hump is up, the second hump is because of left atrium, and this is the normal. And if you see in lead 2, the P wave will show like this: normal right atrial hypertrophy, left atrial hypertrophy, and bilateral atrial hypertrophy. And in V1, you will see like this: normal, this like this, right atrial hypertrophy like this, the second part very deep, left atrial hypertrophy, and this bilateral atrial hypertrophy. Oh, friends, what is the diagnosis in this? Yes, P mitral. Yes. What is diagnosis, friends? P is very tall. P wave, P pulmonale. Okay, very good. COPD. Just looking at the ECG, you can give the diagnosis that patient is having COPD and patient is having some problem. Okay, friends. What is the diagnosis? Yes, very deep, and yeah, maybe left atrial hypertrophy, left atrial hypertrophy. Yes. What is diagnosis? P mitral, left atrial hypertrophy. Okay. So other the abnormalities in this is the normal and atrial flutter. The sawtooth type, if you see, this is atrial flutter. And if you don't see any pattern of the P wave, this will be in atrial fibrillation with irregular pattern. Okay. The next point is our PR interval, and PR interval is 2.5, 2.5. five small boxes or one large box. If PR interval is more than one large box, 0.12 second to point 2 seconds is the normal range. If it is more than 0.2 seconds, this is a prolonged PR interval, first degree heart block. And if it is shorter than 0.12 seconds, this is a short PR interval. This occurs in WPW syndrome, and this is the normal PR interval. You can see P wave. Normally, this part is because of the pause at the AV node, and because of the block, this increases and it goes beyond 0.2 second. Okay, this is PR interval. Friends, what is the diagnosis? Normal PR interval. Okay. Friends, what is the diagnosis? PR interval is more than more than five small boxes. This is first degree heart block. Friends, what is the diagnosis? See P and PR interval. What is the diagnosis? First degree heart block. Friends, what is the diagnosis in this? The PR interval is gradually increasing and then QRS plus drop. So this is MOBIS. This is MOBIS 1. This is MOBIS 1, and the in MOBIS 2 the this is MOBIS 1, this is MOBIS 1 or Venki back phenomenon. The PR interval uh, walks longer, and QRS complex suddenly drops. Venki back walks longer, and suddenly drops. And in MOBIS 2, the QRS complex suddenly drops. Sorry, suddenly drops. It there drops. And this is 2 in 1 block. After every two P waves, one drops. Two P waves, one QRS complex dropping. This is second degree heart block. And this is third degree heart block. This is Venki-Back phenomenon, and this is third degree heart block. You see that P wave is working at its own. All the P waves, all the QRS complexes not equally the same distances and different distances. P is following its own pattern, and QRS complex is wide. This is ventricular rhythm, AV dissociation. Heart rate is 300, 150, 100, 75, 60, 50, 30, 40, 20. Usually the ventricular heart is about 30. So this is severe bradycardia. Whenever you see a strip of severe bradycardia, heart rate 30, 40, think of third degree heart block. Okay, this is third degree heart block. This is, friends, third degree heart block. Very good. So you can see these first degree heart block, second degree heart block, two types, MOBIS 1, MOBIS 2. Venki back phenomenon is the MOBIS 1. MOBIS 2 is suddenly dropping, and the third degree heart block. Okay. So friends, what is the diagnosis in this? What is the diagnosis? Third degree heart block. Very good. Very good. No, friend, this is the short PR interval. This occurs in WPW syndrome. This delta wave WPW syndrome characterized by SVT, supraventricular tachycardia, and accessory pathway. This is the accessory pathway. Before following the normal pathway of AV node bundle of is directly goes into the atria, so the delta wave occurs, and because of this retrograde, following the retrograde stimulation, the SVT occurs and rapid heart rates occur, and the incidence of SVT is very common in the WPW syndrome. Friends, what is the diagnosis? Delta wave. Yes, delta wave. In ECG, you will see like this delta wave. Okay. Now, this next point in our the Saqib's 14 points is the next is the Q wave. Actually, the things which are following are related to the QRS complex, but we will discuss these separately. This is the normal Q wave. Normal Q wave be less than the one third of the height of the R wave. Nor this rule that if it is more than one third of the height of the R wave, this is abnormal. Less than one third of the height, this is in the boxes, small boxes, two small boxes, less than two small boxes, normal Q wave. More than two small boxes, abnormal Q wave. This is pathological Q wave. These are the ischemic changes when there is a myocardial injury. You will see first thing within minutes you will see the peaked T wave, hyperacute T wave. Second thing will be this peak T wave plus the ST segment elevation. Then in the following time in the minutes, 90 minutes, hours, you will see ST segment elevation and T wave inversion. Then in days or weeks, you will see Q wave following and the T wave inversion. And old myocardial infarction, you will see T wave will be normal and Q will be Q waves will be there. This is old. These are the changes which will occur in myocardial injury, developing myocardial infarction. These are the regions which will show you the area of the heart affected. If you see here over the colors, right down, concentrate over here, friends. This is the inferior. In inferior, leads will be 2, 3 AVF. Color is blue. You can see the blue color. You will see Q waves here, T wave here, ST segment. This will be inferior. This will be inferior. Whenever if T wave is inverted, this will be inferior ischemia. If the ST segment is elevated, this is acute myocardial injury, inferior. And if you see Q wave, this is myocardial infarction in the inferior lead. Concentrate over here now. Septal V1, V2, green V1, V2, and this is the artery which will be associated, and this is the side of the heart. In the anterior, friends, they okay. Concentrate over here. Anterior V2, V3, V2, V2, V3, V2, V3, and this will be anterior myocardial infarction. And lateral is V1 AVL, 1 AVL, V5, V6. This is red, and this will be in circumflex artery, and this is left part of the heart. Okay. In these parts, you will in this way you will say that this is T wave inverted in 2, 3 AVF inferior ischemia, 1 AVL V5 V6 T wave inverted. This is lateral ischemia. V1 V2 T wave inverted anterior. This is V1 V2 septal ischemia. So in this way you can label the a part of the heart which is affected. Friends, where is the Q waves? V1, V2, V3. This is abnormal Q wave, ST elevation. This is acute myocardial injury in the anteroseptal part. Anteroseptal part. So next is the our next point is next point is QRS complex. The next point is QRS complex. And as I told you, friends, this part two and a half boxes, this part two and a half boxes, this part two and a half boxes, two and a half, two and a half, two and a half. So if this is more than two and a half boxes, then it is widened. Okay. Next, this is we will see bundle branch block. This QRS complex for the Q waves, for the widened QRS complex, and this and the bundle branch block. Bundled branch block. QRS complex will be widened when the rhythm will be in the ventricles. So for why I am separately mentioning this QRS complex is for the bundle branch block. Concentrate over here, friends. V1 and V2. Concentrate over here. This is normal QRS complex, normal QRS complex. And remember this marrow, RR, right bundle branch, M in the lead V1, and W. This is W. This is W in V6, right bundle branch block. William for left bundle branch block, LL, left bundle branch block, W, this is S and W, M, M pattern in the V6. Okay. And the widened will be in premature ventricular contractions and ventricular rhythm, VT are like that. Okay. And third degree heart block, the QRS complex will be widened. Time is very short. I am already short of time. I will quickly try to cover if I could cover in 5 minutes. Okay. Points are no, we have already almost finished. And now we come to the T wave. This is the T wave. And wave abnormalities will be like this. Biphasic T wave, like this notched bifid. These are usually non-specific changes. The broad or slow or flat. But abnormal T waves will like this. Peaked hyperacute T wave. This will occur in hyperkalemia. This will occur in acute myocardial injury, T wave inversion in ischemia, and this is called ST sag. This will occur in strain, very hypertensive heart. Heart is being pushing against increased SVR, against very high blood pressure. And in this, the QT interval is prolonged. Okay, friends? These symmetric, asymmetric, biphasic, and peaked. Sorry, excuse. This is the ST segment. ST segment. This is the J point. This J point will go over here in acute myocardial injury. And this J point will come down in non-STEMI, RST depression, RST sag, or digoxin toxicity. This is the ST segment. Separately see the ST segment. This is very important. While you're looking at the tracing in the ECG, if the ST segment is elevating, patient is having acute myocardial event, myocardial injury. Okay. Sorry. This is J point going up, ST segment elevation. J point going down, ST depression. And these are different types of the ST segment depression. This is up sloping, down sloping, and horizontal. But you should concentrate on the depression or elevation. This is STEMI, ST segment elevation, Q wave. This is ST segment elevated myocardial infarction. And next is the QT interval. This is the QT interval. Starting from the Q wave to the end of the T wave, this is QT interval, and this is normally 0.36 to 0.44 second. 0.36 to 0.44 second. And zero point 9 to 11 small boxes. 9 to 11 small boxes. And this QT interval is sometimes shortened and sometimes prolonged. So friends, this QT interval, this you can see normal QT interval, a normal QT interval, you can see, and over here is prolonged QT interval, prolonged QT interval. Here, over here, prolonged QT interval. Hypocalcemia, hypokalemia. Both these go down, QT interval is goes long. These go, both these go down, QT interval goes longer. These go up, QT interval goes short. These go up, QT interval goes hyperkalemia, hypercalcemia, QT interval goes short. Hypokalemia, hypocalcemia, QT interval goes longer. Okay. And other the causes are QT interval going beyond 0.44 second are the erythrocene overdose and 1A antiarrhythmic drug poisoning. Antiarrhythmics अगर ज़्यादा हो जाएंगी तो वो होगा. And next is the QT interval shorter will be in the hypercalcemia, hyperkalemia, and 1B antiarrhythmic poisoning. Okay, okay, friends. थक तो नहीं गए? Okay. No, next point is the in the Saqib's key is the left ventricular hypertrophy. This you will calculate by the SV2 and RV5. If it is equal to 35 or more than 35, the left ventricular is hypertrophied. You will calculate the boxes 1, 2, 3, 4. 4 5 are 20. 1, 2, 3, 4, 5, 6. 6 5 are 30. 30 and 20. This will be 50, about 46, 46 millimeter. If it is more than 35, SV2 our left ventricular is hypertrophy. In second, you can diagnose. Okay, okay, friends. This is left ventricular hypertrophy. This is normal. This is very high. This is deep. And now we come to the right ventricular hypertrophy. How you will diagnose right ventricular hypertrophy? You will diagnose right ventricular hypertrophy by looking at V1. If the R wave in V1 is equal to 7 small boxes or more than 7 small boxes, right ventricular, there is right ventricular hypertrophy. Right ventricular right ventricle is hypertrophy. If it is more than 5 small boxes. Okay, friends. This is left ventricular hypertrophy. This is right ventricular hypertrophy. Okay. V1 more than 7 small boxes is the 10 small boxes, and in V2 this is 1, 2, 3, 4, 5, 20 plus RN uh, RN V5 1, 2, 3, 4, 5, 6. You can see that is left ventricular hypertrophy. Okay, friends. These are the changes in this. You can see the hypokalemia and the hyperkalemia, and because of the shortage of time, we may not be. You can see this is peaked, tall T wave, prolonged PR interval, flattened this P wave, widened QRS complex, and ST depression. And in the hypokalemia, you can see flattening or down going T wave and increasing U wave, prolonged PR interval, and slightly peaked P wave, and this shallow T wave and ST segment depression. ST segment very important in hypokalemia. ST segment and U wave. This will be in hypokalemia. This normal hypokalemia, QT interval prolonged hypokalemia, tall T wave, hypocalcemia, prolonged QT interval. When you see prolonged QT interval, single strip, you can diagnose hypocalcemia or hypokalemia. And if the QT interval is shortened, you can diagnose hypercalcemia. Okay, friends. These are the changes in digital. I just want to stress on this ST segment depression. This is reverse hockey sign, reverse sign. This occurs in digitalis or digoxin toxicity. Okay, thank you, friends. आज मैंने आपको काफी तंग किया और learned something. Inshallah, I thank you all for this patient listening. If you have any questions, we can answer those questions. Over to Dr. Amir Furqan.
जी, thank you so much, sir. Very detailed presentation on this very important topic. Definitely ये बड़ा important है और डे बाय डे हमारी मॉनिटरिंग में बड़ा कंसर्न है, तो जो आपने टाइम दिया है इट्स जस्टिफाइड. सो अभी पार्टिसिपेंट्स में किसी के जहन में कोई क्वेश्चन होगा तो डेफिनेटली इसको हम डिबेट में लेके आएंगे.
आई थिंक आई एम इन टाइम, लेकिन आप डिस्कशन के लिए टाइम नहीं छोड़ा, लेकिन टॉपिक बहुत बड़ा था, तो
हाँ जी, ऐसे
इसलिए दैट्स व्हाई. हाँ जी, so I quickly try to cover all these things, and I hope you have learned something you have learned, and I think, yes, that I have uh, make my I have a fruit I have made a fruitful effort I have conveyed something, some knowledge to you. Okay, any questions?
जी डॉक्टर तनवीर आप अनम्यूट करें. जी
अस्सलाम वालेकुम साकिब साहब, साकिब भाई.
वालेकुम सलाम.
माशाल्लाह, समथिंग नहीं सर, आपने तो पूरी ईसीजी माशाल्लाह रिवाइज करा दी. मेरी तो एटलीस्ट रिवाइज होगी ईसीजी.
साउंड प्रॉब्लम सर.
सो आई
जनाब
थिंक मेरा ख्याल है
वेलकम.
जो एनेस्थेटिस्ट को चाहिए ईसीजी वो सारी आपने कर दी है एक्सप्लेन, और बहुत जबरदस्त, एक्सीलेंट एक्सीलेंट प्रेजेंटेशन. तो जस्ट मैं चाहता हूं कि जो हमारे ट्रेनी हैं, क्योंकि ये ईसीजी का नॉलेज एक दिन में नहीं होता है, इसको गैदर करना पड़ता है स्लोली स्लोली. जिस तरह आप एक्सपीरियंस होते जाते हैं ना, तो स्लोली आपकी जो है स्किल ये ईसीजी वगैरह की ये भी ऐड होती जाती है. तो ब्रीफली यानी कि मेरा ख्याल है कि 5-6 चीजें आप दोबारा से काइंडली बता दें जो अहम तरीन हैं, जिन्हें बिल्कुल हम मिस ना करें. उसमें जैसे रिदम है, मोस्ट इम्पोर्टेंट है, वो मिस नहीं होना चाहिए. और खास तौर पे कोई ड्यूरिंग मॉनिटरिंग अगर कोई आप सिग्निफिकेंट चेंज फील करें कि ईसीजी जो स्टार्ट हमने ली थी उससे इट हैज चेंज्ड एंड सिग्निफिकेंटली चेंज, तो वो कंसर्न रेज कर दे ट्रेनिंग को. मेरा ख्याल है इस वो 5-6 चीजें आप थोड़ी सी दोबारा एक्सप्लेन कर दीजिए, द मोस्ट इम्पोर्टेंट थिंग, जिनके ऊपर फर्दर वो बिल्ड करते जाएं अपना नॉलेज.
सर उसमें यह है कि व्हेन यू आर लुकिंग एट द ट्रेसिंग you will see that you will concentrate on the P wave, QRS complex, and the ST segment. The pattern, the regularity of the complexes, and you will concentrate on the ST segment, P wave, and you will keep in mind the first tracing of the ECG. If you have any doubt, you can see the ECG which have been done in the previous ECG. You can compare with that. But the irregularities or the arrhythmias which we usually see during our anesthesia practice is the tachycardia. Sinus tachycardia, and sometimes SVT, heart rate goes up to 160, 170. And the second thing which we come across is the atrial fibrillation. Very common presentation in the old age patients, in the patients with the COPD, patients with the hypertension. These patients present with the atrial fibrillation. Another thing which we notice the abnormality is the ectopics, frequent ectopics. These are very disturbing. And if you count in 1 minute, if the ectopics are 5 or more than 5, then you should be concerned. You can give injection lidocaine, you can give this carotid sinus massage and like that, and this will help. You can further go for pharmacotherapy, but these are the things which usually affect us. And sometimes rarely, but we see that when patient become very hypertensive, there is ST sag. ST sag starts coming in the in the ST segment. ST segment is nothing but it is ST's depression in a hypertensive patient. So these are the things. And we also see T wave inversion in ischemic heart disease patients. And sometimes the QRS complexes, they are widened. And rarely you may see ventricular tachycardia, run of ventricular tachycardias in some very serious patients. And you should concentrate on these things. But whenever you're seeing the ECG, start seeing like the PQRST. Where is the PQRST? Always keep on reminding yourself, PQRST. Where is the P? So when you will start looking like this, there is no P. It is atrial fibrillation. So like this. डॉक्टर तनवीर, आपको देख के बहुत खुशी होती है.
थैंक यू. बिलीव मी, मेरे पास यानी कि अगर ड्यूटी ना हो तो हमेशा मैं वेट करता हूँ अपने ग्रुप का ना, और मैं रियली, और इनफैक्ट आई केप्ट वेटिंग 1 week फॉर ईसीजी. एंड क्योंकि मुझे खुद रिवाइज करनी थी और आपने इतनी डिटेल में बताई कि बहुत सारी चीजें रिवाइज हो गई. थैंक यू वेरी मच.
Thank you so much for your appreciation, sir.
या
ये
दैट्स रियली रियली ग्रेट. और
सर हम
मेरी
आपसे भी कोई प्रेजेंटेशन चाहेंगे. आपको अपना टॉपिक अपना कोई भी चूज करके हमें बता दें एंड गिव अस अ प्रेजेंटेशन.
जी सर
दैट्स
से
फाइन. मेरा ज्यादातर होता है काम इसमें ऑब्स्टेट्रिक एनेस्थीसिया में, मैटरनिटी में. उसमें मैं इंशाल्लाह जो थोड़ा बहुत मुझे पता है मैं जरूर शेयर करूंगा
वो
दोस्तों के
सर से
साथ.
हमारी कमिटमेंट हुई भी है, ये ऑप्स और गायनी वाला जब मॉड्यूल शुरू होगा तो हम सर से लेंगे उसमें.
इंशाल्लाह.
थैंक
ठीक
यू.
है.
आई थिंक
मेरा ख्याल है कुछ ट्रेनिंग बोले उन्हें आज जरूर बोलना चाहिए 4-5 लोगों को.
हाँ यस, कोई कमेंट
हाँ.
देना चाहे, कोई क्वेश्चन पूछना चाहे, एनी कंफ्यूजन.
अच्छा जी, ये क्वेश्चन एक आ रहा है. प्लीज डिस्कस द सिग्निफिकेंस ऑफ एक्सिस डेविएशन.
जी
असल में ना टाइम वाज वेरी शॉर्ट, सो आई कुड नॉट डिस्कस द थिंग्स. एक्सिस डेविएशन जो है ये दिस अकर्स बिकॉज ऑफ टू थिंग्स. Because of the abnormality of the conducting system, conducting pathways, and because of the abnormality of the myocardium. If myocardium is hypertrophied, it will pull the vector or pull the axis towards itself. Left ventricular hypertrophy, the axis will go into the towards the left side. Right ventricular hypertrophy, axis will go towards the left side. And if there is blockade of the left ventral branch block, the axis will first go towards the right side, right axis deviation. And if the bundle branch right ventral branch is blocked, axis will go to it. So the axis will tell you that the myocardium is either enlarged or the conducting pathway is abnormal. And sometimes the ectopic beat, ectopic pacemaker, it also changes the axis of the vector. So these 2-3 things, these will change the axis. I hope I have answered your question.
आई थिंक टाइम ज्यादा हो गया तो इसलिए लोग अब बोल नहीं रहे.
ज्यादा हो गया. कुछ क्वेश्चंस आ रहे हैं. अगर कोई और क्वेश्चन अगर आप पूछना चाहते हैं सर तो देख लें. क्वेश्चंस आ रहे हैं कुछ. हाँ, कोई और क्वेश्चन है?
हाँ, अगर उसमें यह है कि अगर बाद में भी इनके ज़हन में कोई क्वेश्चन हो तो व्हाट्सएप ग्रुप में भी शेयर कर सकते
हाँ,
हैं.
वो आप उसमें डियर फ्रेंड्स आप इस तरह करें ना, आप उसमें अपने क्वेश्चन जो है ना उसमें अपने व्हाट्सएप ग्रुप में डाल दें और वी विल आंसर इंशाल्लाह इन द ग्रुप. है अभी
जी.
टाइम ज्यादा हो गया और
जी,
हमें
जी.
अभी जो है ना बंद करना चाहिए इसको
हाँ, बिल्कुल.
और हमें सोना चाहिए. सुबह उठ के नमाज पढ़ेंगे.
जी सर, उसमें यह है
थैंक यू सो मच
कि
एवरीबॉडी.
जी सर, थैंक यू सो मच सर, एक्सीलेंट प्रेजेंटेशन. डॉक्टर रजिया का एक क्वेश्चन है, चलिए देख लेते हैं बिफोर एंडिंग. जी डॉक्टर रजिया अनम्यूट करें.
अस्सलाम वालेकुम. मैं कह रही थी मैग्नीशियम में भी मैग्नीशियम के चेंजेस बता दें ईसीजी में.
मैग्नीशियम में वही होती हैं जो कैल्शियम में होती हैं, वही तकरीबन होती हैं सारी. मुझे एग्जैक्टली अभी इसको याद नहीं है, लेकिन मैं आपको देख के जो है ना उसमें ग्रुप में इंशाल्लाह शेयर कर दूंगा कि मैग्नीशियम जो है. लेकिन मैग्नीशियम आल्सो बिहेव्स एज जो है ना वो. और मैग्नीशियम जो है ना हम यूजुअली देते हैं उसमें क्लैम्पशिया में. और मैग्नीशियम हाइपर मैग्नीशियमिया जो है इट कॉजेज डिप्रेसेस द मायोकार्डियम एंड द मसल्स. और जब मैग्नीशियम ज्यादा होती जाती है, 2 से शुरू होती है और 5 पे जाके इसका थेरेप्यूटिक लेवल शुरू होता है. 6 पे जो है ना ये इफेक्ट करना शुरू करती है. 8 पे इसकी जो है वो 8 पे जाके इसकी टॉक्सिसिटी शुरू हो जाती है. तो नैरो इसका थोड़ा सा थेरेप्यूटिक इंडेक्स होता है. और अगर ज्यादा हो तो फिर मेनली इसका रेस्पिरेटरी डिप्रेशन पे आता है और फर्दर फिर जाके ये मायोकार्डियल डिप्रेशन करेगी अगर ज्यादा वो होगी. तो उसमें है, तो एग्जैक्टली जो है वो मैग्नीशियम मैंने रिवाइज नहीं की है, लेकिन आई विल इंशाल्लाह शेयर इन द ग्रुप आफ्टर सीइंग व्हाट आर द चेंजेस ऑफ magnesium hypomagnesemia and hypermagnesemia. Or clinically, you will face this magnesium disturbance while you are treating the preeclamptic patients with the mag self. When you are treating, we monitor the magnesium levels, and we also monitor the respiration of the patient. Okay, Dr. Azia.
जी, थैंक यू सो मच एवरीबॉडी। यहाँ पे हम वाइंड अप करते हैं, एंड इन केस ऑफ एनी क्वेरी यू कैन आस्क इन व्हाट्सएप ग्रुप। और फर्दर जो है ना, नेक्स्ट फ्राइडे हमारी जो क्लास होगी वो प्री ऑपरेटिव असेसमेंट ऑफ पेशेंट विद कार्डियक डिजीजेज फॉर नॉन कार्डियक सर्जरी, तो उस पर हम प्रेजेंटेशन लेंगे। होपफुली मैं या डॉक्टर अरसलान कुरैशी में से कोई लेगा, तो इसको हम फर्दर फिर प्लान करके आपके साथ शेयर कर देंगे। सो थैंक यू सो मच एंड गुड बाय।